case, it's not Monday for everyone, since our guest speakers in Australia, they have the leg up. It's already Tuesday on the other side of the world. And I was peeking at the registrations. I think we have some Australians who registered and hopefully have joined too. We'll scan through the pictures and see who's, drinking coffee in their pajamas. But actually, everyone just wears pajamas all day anyway, so maybe that's not a good distinguishing feature. Well, I will go ahead and turn it over to our host, Dr. Subramanian. I'll just, before I do that, I'll again say welcome on behalf of PMD Alliance. My name is Andrea, and I'm so glad that you are tuning in to join us today. As everyone, I believe, knows by now, send in your questions via the chat bar. And just so you know, those of you who have tuned into a lot of this, one of my favorite parts of this series is that it's not just a textbook lecture on here's the symptoms of PD, but we get to know a little bit beyond the white coat about the people presenting. So for those of you who maybe are curious and, when are we going to talk about Parkinson's? We'll get there. It's a journey. Sit back, enjoy the ride. And without any further ado, I'll let Dr. Subramanian, I'll let you begin our journey with Dr. Padmakumar today.
Great. Welcome everyone to our physically distanced, socially connected universe. And just a minute ago, there was a few dogs that were kind of connecting internationally here, barking at each other through our Zoom as we were doing our pre-meeting prep here. So it is not just us that are distanced, but our pets as well. It's with great pleasure that I've been bringing some international speakers to this forum, and it's just been really interesting to learn about how Parkinson's care is practiced throughout the world. And we've had an opportunity to learn about some folks in the UK, and Simon Lewis, who's a good friend of Dr. Padmakumar, has also joined us to speak about GAIT, and we'll have a few other Australian speakers coming up as well in the series. But it's with great pleasure that I bring you my friend, Dr. Padmakumar. He hosts an amazing meeting yearly or every 2 years, bringing together world thought leaders throughout various fields to really bring minds together to help with geriatrics and aging patients, but also to learn about how people are practicing Parkinson's throughout Asia, throughout New Zealand and Australia. He has a number of guests that are from the UK, and through that I met a number of the speakers that will be coming up as well. He works really closely with Professor Chowdhury, who's been on this series, and he actually trained with him at Queen Square for a little while. So Padma, as we like to call him, is a consultant geriatrician and a clinical leader of the aged care at John Hunter Hospital in Australia. And so that's in a very beautiful part of Australia, which I had the pleasure of visiting in Newcastle. And they have just a beautiful hospital set up and a really interesting kind of meeting of the minds. In Australia, it seems, and we will tease this out a little bit, a lot of geriatricians are very involved in care of Parkinson's patients, which makes a lot of sense in places that have underserved communities. And it's something that we might think about doing a little bit more here in the US, as we've already pointed out. A lot of our patients don't get care through a neurologist and really are seeking specialty opinions. And so we might learn from how this care is given throughout the world. And so without further ado, I wanted to introduce Padma and maybe have him tell us a little bit about his journey to where he is now, from India to where he is now in that beautiful part of Australia. He's in some regions that are near some beautiful wine country, and also how he became a geriatrician, and then how he's been focused on Parkinson's, maybe.
Morning, Indu, and many thanks for your inviting me to join this wonderful web series of lectures. And thanks for all the hard work put in by the PMD Alliance, Andrea, Rachel. It is a big thing that you're doing, bringing all of us together in this very difficult pandemic time. So, many congrats for your hard work, and thanks for your invite. So to start with, how I became a geriatrician. I'm a generalist at heart. I'm not a single organ doctor. or I'm not a specialist dealing with one problem. I believe in the totality of things. That's one of the reasons why I took up general medicine as a career. After general medicine, I went to the UK and trained in geriatric medicine, which I still believe is not a specialty. It's just an extension of general medicine, if you add the title older person to it. After becoming a geriatrician, again, the generality interested me. So the only geriatric syndrome I can confidently say, which is very general in outlook, is Parkinson's disease with its multiple protein manifestations. So for me, it was just an evolving career pathways and something which I really enjoyed doing. And one of the things that I learned after coming to Australia, I came here after being a consultant, is that the practice as a physician should not be just restrained to your clinic rooms or your wards or wherever you are. I spent a large part of my time on road, literally knocking on doors of people with Parkinson's disease. And I must say, over the last 10, 15 years I've been here, that has really improved my outlook on Parkinson's disease and people with Parkinson's disease. There's nothing like the first-hand information you will gain by seeing how patients live, and especially the carers who look after them, which we don't get in a hospital setting, because you get, what, 20 minutes, 30 minutes max with the patient and the carer when they come to the hospital. So that has been a really revealing experience for me. But my training in Parkinson's disease is from UK. Almost 25 years back, I started doing Parkinson's disease clinic as a junior doctor. For the first 10 years, I got no clue of what I was doing. That has slightly improved, I must say, after all these years, but still doesn't have much clue what's going on, because this disease is so vast, and the closer you get to it, you just realize that you're facing a mountain. So yeah, that's my background, and that's what I enjoy doing now.
Wow, I didn't really know about your home visits. We'll try to tease those out a little bit more, because I think that can be really telling, and it's something that we don't do enough of here, and I'd love to hear more about that. But without further ado, maybe I'll let you, I know you've prepared a talk for us around a case study of yours, and we're going to be focusing mostly on some of the complexity of the autonomic nervous system and some of the non-motor symptoms, which I know you've learned a lot from Professor Chowdhury about as well. So why don't we start with your talk, and then we can kind of find some questions along the way, and I'd love to tease more out as we go about the home visits that you've been doing.
Yep. Right, this is where I might get a bit stuck. I'm trying to find my talk. I believe it's not coming up, even though I had it on the screen. Excuse me.
No worries. I think you guys might have a backup copy I saw floating around too, right, Andrea?
Yes, I can.
It's here. It's here. I can't just seem to get it on the screen.
Dr. Padmakumar, I can share it for you if you like. If you just let me know when to go to the next slide, I'm happy to do that for you.
Yeah, but I'm not sure why it's not showing up on this.
Don't worry about it. We'll get Rebecca as the IT queen there. So
fair enough. Yeah.
Can you see that okay?
Yep. Yep. Yay.
Yep. Yeah. So that was my introduction, and yeah, shall we start the presentation?
Yep.
So like I said, this is a clinical talk, which means I'm a clinician. I'm not an academic geriatrician. And it is very difficult to talk about autonomic dysfunction in an older person with PD on his own. That's mainly because geriatrics and older people with Parkinson's disease, many of the clinical issues tend to overlap. So it's very difficult to tease out one issue and talk about it. You need to look at the person as a whole and then address it. So in my slides, I will try to show you what are the issues with advancing PD in it, and then discuss upon autonomic dysfunction. Yep. So here is John and here is Beth. John has got Parkinson's disease. As you can see, they're not real people. There are two characters that I've learned from my work in geriatrics dealing with Parkinson's disease, but I can assure you they reflect majority of the problems that an older person with Parkinson's disease is going through. So let's talk about John first.
Next slide.
Yeah. So John is 82. He now lives in regional New South Wales. He used to live in a big sprawling metropolis. After his retirement, when he was 75, he was diagnosed with idiopathic Parkinson's disease. He was under neurology service, but after retirement, he found it quite difficult to live in a big city. So he thought he'll get a bit of fresh air, and I will show you what that fresh air meant over the next few slides, please. So he's well managed with medications. He's on almost maximum of L-DOPA. He's on monoamine oxidase inhibitors. He's on COMT, a combination Stalevo, and he's on a dopamine agonist. What I'm trying to tell you is he's optimally managed and is nearing the maximum limit of many of his medications. Next slide, please. So this is his backyard, so you can't blame him for wishing for a change of scene. Yep, keep going for the next few slides. And that's what he looks from his bedroom window now. And he's taken to gardening, so he's growing some flowers, veggies, and fruits in the next slide. So he's really enjoying his retirement life, and 5 minutes down the road, that is what you get. So you can't blame him for opting out to live in the regional New South Wales. Okay, let's talk about Beth. Now, the reason why we have to talk about Beth is very important, mainly because the treatment of an older person with Parkinson's disease is not complete unless you talk about the carer and proactively address the issue they're going through. That's mainly because when we see someone with Parkinson's disease in a hospital setting, we tend to concentrate on the issues, quite understandably so, of the patient. But we walk away from that situation after half an hour or 1 hour or after an MDT in an inpatient ward. What they're left with is the carer to look after them at home. And it's a 24/7 job, 365 days a week. So there will be naturally carer stress addressing, and the management of an older person is not complete unless we look at the carer as well. Okay, next slide. And as you can see with this advancing Parkinson's disease, that's shown by his H and Y staging, he's needing more and more assistance, which is not surprising as the disease progresses. Next slide. He's falling quite a lot, as we have listened to Professor Lewis in his wonderful talk a few weeks back. There are many reasons neurologically why he could fall. And he's a big bloke, to borrow an Aussie slang, so it's not easy to pick him up. And Beth herself had a fall, trying to stop him from falling, and she suffered a broken wrist as well. Next slide. Nights are becoming nightmares now. He needs to get up multiple times during the night. Again, there was a wonderful talk by Dr. Paniker on bladder dysfunction. So 10 times every night he needs to get up. And he started a new symptom, that is, he's hitting out while he's sleeping, and which leaves Beth's face black and blue the next day morning. She can sleep in another room, but she doesn't want to do that because he might fall if she does that. Next slide. Those are all the physical things which Beth is quite okay to manage, but he has changed as a person, which is what she's struggling. Previously, John used to be a very calm, a very pleasant person, very caring, very compassionate. That has changed now. He's become, again, to borrow another Aussie slang, he's becoming a bit cranky. He's abrupt, he's very short, he's having a short fuse, and he's become very insecure. He's hanging on to Beth so much so that she can't go out to the village and do what the things that she enjoyed with. Next slide. He can get very frustrated, and not that the agitation and the aggression is increasing, but there is worryingly there are some paranoid, suspicious behavior also creeping up, which really upsets Beth. Next slide, please. And hallucinations have started coming. He's seeing people coming in and out of the house. The living room is full of strangers, and he suspects that they're there to talk to Beth, which is really hurting Beth. And little kids are playing in the yard. He will ask them to keep out or shut up. They won't listen to him. And come nighttime, evening time, spiders and creepy crawlies are coming all over the ceiling and the floor. Next slide. Whenever he's sitting down in the breakfast table, having his meal, he's slumping forward numerous times. He's feeling tired. When he gets up from his chair and walk around, he's feeling dizzy. He needs to hang on to something. Many times he has had blackouts. Ambulance have been called. And the local hospital is very, very minimal. They've noted that his blood pressure had been very low. 2 or 3 pints of fluid and he's back home. Multiple admissions, again with constipation, which is not responding to regular laxatives. Yep. He has withdrawn into a cocoon now. He has stopped going out. That is mainly because of the drooling of saliva. It's become a big social problem for him. He has lost interest in his wireless, in his carpentry. So he has become a very changed man. Yes. So needless to say, they're getting a bit fed up now. It has definitely taken a toll on Beth's physical as well as mental health. She's seeing a psychologist. They are in a rural area, so I've shown you beautiful, but that rural means not easy to get a full care package. So carers are finding it difficult to get there as well. So on talking to Beth, it's not the tremors or it's not the bradykinesia or the rigidity that's worrying her now. These are her list of problems: the falls, the blacking outs, the constipation, and the nightmares at nighttime. Okay, so what we are dealing with is this picture. So this is an analogy to non-motor symptoms. When someone with Parkinson's disease comes to a clinic room or the hospital bed, what we see when they walk in are the motor symptom, that's the tip above the water. We don't see what goes on beneath the surface, and that's where the non-motor symptoms come in. Next slide. So this is non-motor symptoms are nothing new. The good doctor, Dr. James Parkinson, described it 200 years back, to be precise, 203 years back. The sleep disturbance, the drooling of saliva, the gut problems, and look at the last sentence. Sleep, everything had been described by him at that time itself. Next slide. Now we know, after a lot of research over the last 20 years, the non-motor symptoms can be there 10, 20 years before the development of motor symptoms. That is, before the diagnosis of Parkinson's disease, patients can have non-motor symptoms, but obviously the connection was never made because they were not recognized as related to Parkinson's disease. And now we also know that as the disease progresses in the last 2 decades, they predominate the clinical picture. Next slide. And we need to be thankful for Dr. Braak. He was a neuropathologist. He and his wife, both neuropathologists, brought out this wonderful paper in 2003. They studied the brains of people who died of Parkinson's disease and related disorders. They pulled out their GP records and they noted that 10, 20 years before they were diagnosed with Parkinson's disease, they developed constipation. Then they developed anosmia. Then they developed sleep disturbance and they developed autonomic problems. So till then, the standard teaching was Parkinson's disease is a disease of the brain, basal ganglia is affected, neurons die, and that's why you get tremors and other clinical features of Parkinson's disease. Braak changed all of that. He, with good evidence, he documented that the first change happening in the body is in the myendric plexus, in the nerves lining the large bowel, producing a constipation as the first symptom, followed by loss of smell affecting the nasal epithelium, then the lower parts of the brain where there are 2 structures called the pons and the medulla. They are the autonomic centers of the brain. That is, they are the centers which control the autonomic function in the body. They're affected. When I say they're affected, next slide, please. When I say they're affected, I mean there are clumps of this abnormal protein, which we now know as alpha-synuclein. They replace the normal nerve cells found in these brain cells. Next slide. So there's a landmark study which has come out from Sydney. That's the multicentric study of Parkinson's disease, where they followed more than 500 patients over a large period of time, more than 20 years. Next slide. And they noted that symptomatic drop in postural blood pressure, which is due to autonomic dysfunction, is present in every other person. that is after 20 years of getting Parkinson's disease, all these symptoms, dementia, hallucinations, or urinary incontinence, excessive daytime sleep, they are predominant in the clinical picture. Next paragraph. Sorry, next slide. Yeah. So, like I said, the nerve cells in the pons and the medulla, they are replaced by clumps of protein, alpha-synuclein, and they affect the blood pressure control of the body. And we now know that in multi-system atrophy, or MSA, which is a Parkinson plus syndrome, that is the presenting feature. They're very common in advancing Parkinson's disease, in idiopathic Parkinson's disease as well. So next slide. So who gets this autonomic dysfunction? I think broadly we can divide Parkinson's disease presentation into tremor predominant Parkinson's disease or patients without any tremor. So they are the group which some neurologists tend to call akinetic Parkinson's disease. They present with a very characteristic clinical presentation, that is postural instability gait disorder. The tone in the trunk is quite predominantly increased compared to the upper limbs, and they don't have tremor. When they stand up, there is a tendency for the body to arch forward, the knees are flexed, and we now know that the autonomic dysfunction is more predominantly prevalent in this group. Not only autonomic dysfunction, they also have other non-motor symptoms, neuropsychiatric manifestations, and dementia in this age group. Next slide, please. So one of the reasons why John is falling, the reason why I'm saying one of the reasons is we know that one of the main reasons why patients with Parkinson's disease fall is loss of postural reflexes and freezing of gait. One of the reasons why he's falling is due to autonomic dysfunction. That means when he stands up or walks around, his blood pressure drops. We call it symptomatic postural hypotension. Next slide, please. So as I was saying before, vagus nucleus, that's a cranial nerve nucleus, that they control the autonomic system in the body. By saying that, I mean the nerves that goes to the blood pressure, the blood vessel walls are affected. Many neurotransmitters, cholinergic system, sympathetic system, serotonin, dopamine, they're all affected in this dysfunction. And how they manifest based on these symptoms, orthostatic dizziness. Some people get pain along the shoulder girdle because of this low blood pressure, constipation, bladder dysfunction, problems with sweating, hyperhidrosis, and erectile dysfunction. Next slide. Yeah. Now, postural hypotension is very common in Parkinson's disease, but it's not just the postural drop in blood pressure. When persons with Parkinson's disease lie down, their blood pressure is quite high. We call it supine hypertension. So that becomes a big management issue. So the main way which doctors tend to manage the postural drop in blood pressure is to reduce or stop the blood pressure medications. But then when they lie down, the blood pressure goes high. And that happens especially in the middle of the night. So we now know that high blood pressures, especially happening after midnight, can produce increased cerebrovascular as well as increased cardiovascular problems. So it's important to address that as well. That is where an often underused tool is a 24-hour Holter monitor, which is a very easy thing to do. Just a blood pressure cuff around the arm for 24 hours, automatically checks the blood pressure every 30 minutes. So the reason why we are doing it is we want to know what the blood pressure is doing after middle of the night when everyone is sleeping. If the blood pressures are high in that particular group, which we tend to call non-dippers, then we need to give them a blood pressure lowering medication, ideally before they go to sleep as well. So that is why the management of postural hypotension becomes a bit of a challenge, especially in older person. It's not just the drop in blood pressure, but it's the very high blood pressure that can happen as well when people sleep. Next slide, please. The fundamental step in managing orthostatic hypotension is to make sure we got it right. And that starts with checking the blood pressure properly. When I say properly, I mean the patient must be lying down to begin with. Ideally, wait a few minutes till the patient is resting and then check the blood pressure. Then the patient must stand up for 3 minutes minimum, ideally 5 minutes. and then check the second blood pressure. The reason why I'm saying this is this, I fully understand, may not be happening in every clinic because of understandably concerned with time. But if you don't do it properly, we may miss a drop in blood pressure. The theoretical definition goes by a fall in systolic blood pressure by 20 or a diastolic blood pressure by 10. But it is important to know that it's not just the numbers. Patients should have symptoms as well. I'll try to explain why. Next slide, please. This is a very important slide in this presentation. The reason why I'm saying this is a very important slide is we know that the disease produces autonomic dysfunction and hence drop in blood pressure. But it's not just the disease which do that. The medication that one takes for Parkinson's disease, predominantly L-DOPA and all the other medication, will do exactly the same thing. That is, they will reduce the blood pressure. So the first trigger jerk response may be, we will all be quite tempted to reduce the medication. No harm in it, provided that does not slow up the patient and make him or her more safe. So what we need is an ideal middle of the road approach by which we should be cutting down on the Parkinson medication, but at the same time, not impinging on the mobility of the person. So at some stage, this middle of the road approach won't work, and we may have to bite the bullet and start medical management of this low blood pressure. I'll come to that, but it is important to stress that at no stage should there be drastic measures of stopping the Parkinson medication, saying that many patients can be unduly sensitive to L-DOPA and they can have profound drops in blood pressure as well. But that just shows how complicated this medical decision will be. Next slide, please. It's all about water. The management of postural hypotension is quite simple, more water. And I will tell you how it works. Next slide. There has been randomized controlled trials, which tells us that the best treatment for postural hypotension is 2 liters of cold water. You might ask me why cold. There is some evidence to show that cold water triggers vasoconstriction. And there's been some anecdotal evidence that 1 glass of cold water first thing in the morning before getting out of the bed sets the tone for the rest of the day. So that might be something to consider. Compression stockings work, but they need to be up to the hips. When you're prescribing compression stockings, it has to be remembered that they're not easy to put on, and they can be quite cumbersome, and many times it needs a very strong carer to put it on, especially up to the hips. Next slide, please. There are some other small tips as well. Cut down the meals to small quantities, have multiple meals. The main reason for that being a full tummy means a lot of blood is diverted to the splanchnic circulation. That means the circulation around the tummy, which aids with the absorption of the food, which means rest of the blood vasculature doesn't have enough blood that can aggravate the postural drop in blood pressure. There's a lot of evidence for coffee. Coffee is very bad for the heart. We all know that, but coffee is very good for this condition because it triggers vasoconstriction by blocking dilatation of the blood vessel. Next slide. And also cutting down the carbs and making alcohol 0 or very minimal will be helpful. People tend to pass out after having hot baths, and that's because if the temperature of the shower is quite high, it can produce quite a lot of dilatation of the blood vessels in the body, and that can produce drop in blood pressure as well. Next slide. Posture is very, very important. I cannot overemphasize the importance of posture. First thing in the morning, getting out of the bed is an important period of time for someone with Parkinson's disease and autonomic dysfunction. I will probably suggest turning to one side of the bed and lying in that position for a few minutes, and then sitting up in the proper position, maybe watch TV if there's a television there, or read the paper if the paper could be delivered up there, but spend some time sitting up, propped up in the bed before even thinking of getting out. Because that change in the position of the body from completely horizontal to a vertical position needs to be taken up very slowly. That sets the tone. Also, avoid sudden changes in posture, like reaching for something in the kitchen shelf or bending down or picking the newspaper from the floor. Don't do that. That can trigger a fall. Again, prolonged standing or prolonged sitting. And churches and hairdressers are two common places where people tend to pass out because of manipulation to the neck when the hair is being dressed, or a prolonged sitting or standing in a church. In those situations, calf training exercises can be very useful in preventing an episode. Next slide, please. For the medical community dealing with autonomic dysfunction, it is very important to know that we shouldn't go by numbers. When I say numbers, I mean the drops in blood pressure. If the blood pressure is checked again properly in every movement disorder clinic, I can show you that more than 80% of patients will have a drop of up to 20 millimeter blood pressure. Doesn't mean that they need treatment. It's very important to go by symptoms. The reason for that being, if a person with Parkinson's disease had been having low blood pressure for a considerable period of time, the brain will make adjustments to that by autoregulation. In other words, the system, the body, is tuned to those low blood pressures. At some point, that autoregulation will fall and the body will struggle. That is when patients get symptoms. And the management, the medical management, should be addressed at that stage when that compensation falls. That is why it's important to ask for symptoms or other. So symptoms may not be just dizziness or falls. Like I said, tiredness, feeling sleepy all the time could be a symptom of Parkinson's disease related autonomic dysfunction. Next slide, please. So the management of Parkinson's disease, I've been talking about the conservative management. That is the second bit, that is increasing the intravascular volume. If those measures fall and a person like John is still blacking out despite all what we've done, then we reach for the tablets. And the tablets are meant to increase the peripheral vascular resistance. Next slide, please. We geriatricians are, as a tribe, we are very hesitant in starting medications. In fact, we are well known for our reputation of stopping medication. Whenever we start tablets, we go for the mildest step first. So the first tablet I will reach for in managing a drop in blood pressure is FLUDROCORTISONE. It works very simple. It increases the sodium reabsorption in the kidneys. So a lot of salt is kept back in the body and not lost in the urine. So that means along with the salt, water will also stay in the body. That's the whole idea, to increase the vascular compartment. Problem being, if the body is already full with water, like in a heart failure, that could be a problem, and we tend not to use this medication in that setting. Also, with the sodium retaining the body, the potassium goes out, so we need to look after the potassium as well. We start with a small dose, 50 microgram per day, then increase gently to maximum of 300 microgram per day. Next slide. But the most potent medication in the management of this condition is a drug called MIDODRINE. And because it's strong, we tend to use it very cautiously. It acts by increasing vasoconstriction, by specifically acting on the alpha receptors on the blood vessels. It is a very powerful medication. It can be started with once a day dose, 2.5. Then we increase it to twice a day, but the second dose is given only in the afternoon, not in the evening, mainly because it can really increase the blood pressure during nighttime. It has to be given on a named patient prescription basis in Australia, mainly because the patient needs to be closely monitored for high blood pressures. Like I said, that is my last resort because it's a very strong medication. Next slide, please. In Australia, we use this medication, which is used commonly in a neurological condition called myasthenia gravis. It's PYRIDOSTIGMINE, and it has been shown to improve drops in blood pressure. The advantage being with this medication is it does not increase the lying blood pressure. In other words, it does not produce hypertension. By saying that, on same measures, it's not that strong. In other words, it's not as strong as FLUDRO or MIDODRINE. So my tendency is to start with FLUDRO. If it's not working, then add on PYRIDOSTIGMINE and then reach for MIDODRINE as the last step. I fully understand that NICE guidelines over in UK are recommending MIDODRINE as the first line now. And with PYRIDOSTIGMINE is well tolerated. Some patients can develop some diarrhea. Other than that, it's a well tolerated medication. Next slide, please. But I understand that in States, you guys are having a new medication called droxidopa, which is supposed to be very strong and doesn't have many side effects of MIDODRINE. We don't have it yet here, so we are waiting hopefully for that. Next slide. So that's the postural hypotension. My talk is autonomic dysfunction, which has some other features as well. So, but I fully understand that many of these are covered or will be covered by speakers in this series. But for completion's sake, I will just breeze through the slides. Sleep is a big problem in Parkinson's disease, not just the nighttime sleep. The nighttime sleep is broken and fragmented, but daytime sleep is excessive. There is one specific sleep problem that I would like to emphasize on, that is called RBD, or rapid eye movement stage sleep behavior disorder. I will explain this before showing you a video. When we sleep, when people sleep, we all dream. That's quite normal. Some of us tend to be affected by bad nightmares, and then we wake up and then that's gone. That's also normal. That's mainly because when we sleep, our skeletal muscles are completely relaxed. That happens because of the brain centers in the pons. Those centers send inhibitory nerve stimulus to the skeletal muscles, making them fully relaxed while we sleep. In Parkinson's disease, those centers are affected. Those centers are replaced by clumps of alpha-synuclein. Hence, that inhibitory stimulus is gone, which means skeletal muscles are not relaxed while patients with Parkinson's disease sleep. They're in a state of rigidity. So what happens is, in the REM sleep stage, when the dreams are more, there is a tendency for patients with Parkinson's disease to enact the dreams. That can produce thrashing out movements, kicking out the legs, and injury to the carer in the bed. So that's what I'm going to show in the next video, in the next slide. Okay, next slide, please. It is quite distressing for the patient and the carer, as you can see. But the good news is it's fully treatable. It's one of the non-motor symptoms that I can confidently say we can totally fix it. The drug of choice is clonazepam. It's a benzodiazepine, started at 0.25 milligram, gradually increased to a maximum of 4. But again, we geriatricians do have a problem because we don't like benzodiazepines. We don't like any drug, to be honest. Mainly because benzodiazepines can produce falls. So we tend to go for a milder one, melatonin. Professor Simon Lewis has done a lot of studies in sleep-related field, and he also recommends it. Melatonin, which people normally take for jet lag, you need a prescription to get that in Australia. Controlled release preparation is effective, should be taken around 6 p.m. and it works. We start with 2 milligram and then gradually goes up. I'm sure the other speakers will be talking more on the sleep in the next sessions. Next slide, please.
I think we might, I think we're at about 2:40 now. We might take some questions because there's a lot of questions actually on your orthostatic hypotension subject. And I know you have other slides as well to talk about, but and that video was really cool, the REM behavior disorder one. Some people have said that that's the first time they've actually seen a video of that ever. In any sort of presentation. So I think that's really helpful. But I do want to have some time for questions on the topic that you have so beautifully talked about. And I think there's also been some clarifications that people wanted to find out about, if that's okay. And then maybe if we have some time at the end, we can go back. That was great. And especially since you have the internal medicine background and the geriatrics background, that gives you sort of a little bit more of a breadth of information around the cardiovascular system and the blood pressure apparatus compared to what many of us in pure neurology have. I think we can you know, gain a lot of insight from you, because this is something that you've taken care of even in, you know, other types of patients and aging patients and even younger patients when you were in your internal medicine training as well, presumably. So maybe we can talk a little bit about a couple of the questions that have come up, if that's okay, and just to clarify. So I think, you know, we covered a number of subjects, and there's just been a few clarifications. One is about the leg exercises and that type of thing. Could you describe how to do those and maybe clarify that a little bit, and when would you try those?
Okay, so it's like going on a long haul flight. The exercises that you tend to do in a long haul flight, which means you walk around, and then one specific exercise is standing against the wall, shoulders touching the wall, and then slowly raise the body on your toes and then come down. In other words, stand against the wall, shoulders touching the wall, and make sure that the foot is also touching the wall, the back side of the foot. It's a bit difficult to explain it. Normally I show it. And then raise yourself and raise the body, and so that the body is standing on the toes, then come down. So do it repeatedly for 5 to 10 minutes. So what we're doing is you're exercising the calf muscles. So the idea being the calf muscles will squeeze the blood vessels in the calf, and they will increase the venous return that's going on. So that's called calf training.
Can you do that in the sitting position too then?
Absolutely, absolutely. So when you're in the sitting position, just keep on raising your leg, and then, you know, it's almost like
you're basically flexing the toes,
yeah.
And then you're sort of relaxing them back. So you're doing this. So that you're getting sort of the gastrocnemius muscle is sort of,
and the soleus, and the
sort of muscle back here.
Yeah,
yeah,
that's one. Yeah.
Okay.
Yeah.
So
flexing the toes or extension, I'm not sure which movement it is. Yeah, but that's the whole idea.
Yeah, you're sort of plantar, because in medicine we say that this is dorsiflexion and this is plantar flexion. So you're extending the toes basically and going into like a ballerina toe, basically.
Absolutely.
And then you're sort of relaxing. And so even if you were sitting in a plane, you could create this. So you're basically tightening the back of your calf, and then that's making the veins pump the blood back to the heart, which is where, and then the veins basically draw the blood back to the heart, and the heart is then pumping things up into the brain. And so when you were talking about the after eating, when all the food is stealing all the blood to get digested. And so this sort of area around your belly, all those vessels are taking up all the blood. And so that's when people can get really at risk for these low blood pressure episodes, is, as you described, first thing in the morning and then after meals, basically. And so we should take extra time. And you described, you know, when you're lying flat and then you sit up, there's a change in your blood pressure. And then from sitting to standing. And so in the morning, you said you want to take your time, and maybe you were saying even read the paper at the side of your bed could be a good thing. And then kind of stand up eventually. So I think that's a good tip for sure.
Read the paper and have your first dose of Medopar or Cinemet, you know, at that time.
And take a glass of cold water too. You have to have somebody bring you cold water maybe in the morning. So, okay. So you're ordering up a bunch of things. So,
sorry, and the calf training is what the compression stockings will do automatically. So that's the advantage of doing it. Many of my patients are 90 plus age-wise, so they have a lot of arthritis in the knees and the ankles. So calf training may not be practically possible for everyone. So that is where the compression stocking, because they do exactly the same job. That's why I'm saying it's not easy to put a compression stocking. They're quite tight, and it needs a strong carer to pull it on. Yeah, carry on.
Yeah, so the compression stockings, some people have a sense that they're like tight socks, but really to work well, you kind of need to get all the way even up into the abdomen. And you even put something about abdominal binding, because you're really trying to hold the lower half of your body, all that blood flow in, and pump it back up to the heart, basically, as best as you can.
Yeah. Look, the compression stockings are not very popular. That's why I didn't even mention about the abdominal binders. So many times I get lucky only up to the knee. So even up to hip doesn't work.
Yeah, they're really, to work well, basically you have to have them be pretty high up. So there's also been a question. So when we're talking about the autonomic nervous system, can you describe a little bit about how that affects temperature as well? in the body? So a lot of patients also say that they're cold or hot or they sweat,
Yeah.
you know, just maybe talk a little bit about that for a second.
Yeah, meaning it's the temperature regulation, that's a big topic in itself. And I don't think we can fully blame the autonomic system for that, because there is evidence now to show that the alpha-synuclein is affecting the hypothalamus. So hypothalamus is a point higher up in the brain, it's almost near the top. And that is the temperature controlling center for the brain. So that hypothalamus is also affected, and there are some neuroendocrine problems around it, why it is affected. So not just it's not one temperature that is affected. Some people find it extremely insensitive to cold, whereas some people find it extremely insensitive to heat. So both can happen. Some patients will have profuse sweating. Some people don't sweat at all. So we don't have enough evidence to recommend any evidence-based medication for that condition. I think that's a lot of work that needs to be done in that. Maybe you might be aware of some medication from a neurologist side, definitely not in geriatrics, but we know that that condition is connected. But it's not just the autonomic dysfunction, even though autonomic dysfunction contributes to it, but hypothalamus is affected. That's the reason why temperature is dysregulated. Yeah.
And then you mentioned cold water in the morning, which is really interesting. I've actually never heard that, so I'm learning some things too. And also, I mean, do you recommend salt in the diet or any sort of? Sometimes I recommend. There's something called Gatorade here that is a sports drink, and sometimes even there's a drink called V8, which is like a very salty tomato juice. And sometimes I'll have the patient eat that or drink that with meals. I don't know if you recommend that at all.
Yeah. Okay. My standard recommendation, which is which the cardiologist will have a coronary event if they hear about this, is big 2-liter jug of water in the kitchen table, a lot of ice, water, 3 or 4 lemons squished in, and half a tablespoon of salt and a touch of sugar. So that is to be consumed before 4 p.m. You don't want nocturia, so it need to be consumed. Extra salt in the cooking, and extra salt in all the marinades in the roast and everything. So, and crisp, people like crisp. So crisp have got plenty of salt. So this is what I recommend for someone with postural hypotension. Needless to say, not an ideal recommendation for any other person with cardiac problems or hypertension. Yeah, but it works. It works really. Yeah.
So crisps are potato chips. That's the Australian word for that. And then we I think the rest doesn't need a translation. So
the advantage, the salt is important. I'm glad you brought that up, because the more salt you take, the more thirsty you will become and the more water you drink. But water is the key.
Absolutely. And talking about curtailing it after a certain point of the day is also important, because some people feel that they have those 2 liters. And I think Boss also brought up, the 2 liters, keep it in your living room and sit around and keep drinking it all day. But when people get behind, they tend to start drinking it towards the end of the day, and then they end up peeing a lot at nighttime, which is already a problem when the autonomic nervous system, so just to clarify, the autonomic nervous system is that automatic kind of nervous system that's working behind the scenes to regulate things like blood pressure, temperature, heart rate. These sorts of things are all part of the autonomic nervous system. It includes things like the bladders under control of that, the bowels and things like that. So all of these things are pretty key, and these are dysregulated in Parkinson's disease. So it's really important. There's a question about what hypokalemia is. Hypokalemia is a potassium. So the letter K, that's a salt in the blood. That can be abnormal when you go on Florinef, and Florinef changes sodium, which is a different electrolyte. So these are things that sometimes we need to get monitoring of certain types of other chemicals and electrolytes and stuff in the body. There's also been a few other thoughts here about things to eat around pickles and potato chips and things like that, and then the bouillon. So that's like a soup cube thing that people will sometimes eat. And then again, these V8 and things like that. There's been a question about young onset Parkinson's and autonomic dysfunction. If somebody gets tremendous autonomic dysfunction early in Parkinson's, can you talk a little bit about your thoughts on that?
Yeah. So early onset autonomic dysfunction in someone with a suspected diagnosis of Parkinson is a red flag. Chances are it is not idiopathic Parkinson disease or the Parkinson disease that we commonly know. It's very, very likely we are dealing with a multiple system atrophy. So multiple system atrophy, or MSA, is a condition where multiple nerve systems in the body are affected. So pyramidal system, extrapyramidal system, parasympathetic autonomic nervous system, almost all systems are affected. And Parkinsonism, or features of Parkinson's disease, will be a manifestation of this condition. There can also be another related condition, especially in very young people. I've seen during my time in the UK, I've seen 20-year-olds with a profound autonomic dysfunction. That's a totally different condition called pure autonomic failure. But if there are features of Parkinson's disease and autonomic dysfunction, especially the postural drop is predominating, it is very likely that we are dealing with a condition called multiple system atrophy. Again, these titles like multiple system atrophy or PSP or Parkinson's disease or Lewy body disease, these are titles, but that shouldn't change the practical management. If there is bradykinesia, we treat it with L-DOPA. If there is autonomic dysfunction, we treat with conservative measures and specific measures. If there is cognitive impairment, we treat it with cholinesterase inhibitors. So we can all be cleverer and wiser only retrospectively. Prospectively, we may not know what this is going to take, which pathway this is going to take. So end of the day, if there is autonomic dysfunction, even in a younger person with suspicious Parkinson's disease, we treat them as we normally treat Parkinson's disease, but it might be in multiple system atrophy that we're dealing with.
Yeah. So to clarify that again, so sometimes there are these Parkinson plus disorders. We're actually going to have Irene Litvand come on and talk a little bit later on this series about other disorders that can look like Parkinsonism with some of these other things like eye movement abnormalities or blood pressure dysregulation, things like that. If you're very early in your disease state and the only thing or one of the main things you have is a lot of blood pressure abnormalities, I would recheck in with your doctor and make sure that there's not something else that's going on. Sometimes it can be another host of medicines. You might be on 3 different blood pressure regulating medicines and something needs to be revisited there. It's not absolutely classic for early classic idiopathic Parkinson's disease to be having a ton of autonomic issues, even if you're young. It's usually, as Dr. Padmakumar showed, later finding in advanced Parkinson, sometimes 10, 15 years down the road, often in an older patient that we're seeing these issues. So it's not very classic that a 40-year-old who's just been diagnosed with Parkinson's has a lot of blood pressure dysregulation. I would revisit the diagnosis, at least from what I'm hearing. So I think that's important. Another thing that I wanted to ask about, so there's been a lot of questions about swallowing issues. I think we have to have probably another whole talk on that because that's another whole series of chats, and we might have a swallow therapist, or maybe the PMD Alliance has some other videos on that. One of the other questions, so you had mentioned the Florinef, so that's the salt sort of, a way to give this sort of entry level starting of increasing vascular volume. And you mentioned, starting low and then going up to 0.3 milligrams maybe at the most. When do you usually prescribe that? Is that usually in the morning or all together at the same time? What's your timing of that?
Morning. FLUDROCORTISONE is always given in the morning. Okay. PYRIDOSTIGMINE given 3 times a day. MIDODRINE twice a day, like I said, the second dose at lunchtime. But saying that, this is individual practice. Mm-hmm. If you look at NICE guidelines, you might find that MIDODRINE is number 1. Even before FLUDRO. My tendency, many of my patients are on all the 3, and still the blood pressure, there is an 80 millimeter drop. So patients are on 3 milligram of 0.3 milligram of FLUDRO, maximum dose of Pyrido, and even 30 milligram of MIDODRINE, and still having problems with that. There, we need to drastically cut down on the dose of L-DOPA. We know that L-DOPA cutting down will work, but the problem is the mobility will be seriously affected in that case.
So just to clarify that, so the Parkinson's medications, they replace dopamine, but dopamine, any sort of form of dopamine replacement can sometimes drop the blood pressure, as can the Parkinson's disease itself. There should never be a time when a Parkinson's patient shows up to a doctor's office and they say, oh, you have low blood pressure, let's take away all your Parkinson's medicines. What you had said is sometimes we slowly start to chip away, maybe look at other pills. Sometimes the bladder medicines can drop blood pressure. Sometimes the blood pressure medicines can drop blood pressure. There might be other things that we can chip away at. if we choose to decide that we've tried some things, we've added maybe some of those Florinef and Midodrine, and we're at a place where we want to reduce the blood pressure medicine, the Parkinson medicine, we should do it slowly over time, reevaluate the blood pressure, reevaluate the stiffness and slowness and gait and things like that, because we don't want to have a dangerous situation where we ever withdraw all Parkinson medicine, then end up, you know, having, there's actually ways that you can withdraw and actually it can be quite harmful to the nervous system and the muscles and things from rapid withdrawal. So I think that's definitely helpful. There's also been a question. So here we don't use a lot of pyridostigmine, and we do use Midodrine and Florinef, probably Florinef, like you said first. We do the measures, the conservative measures, as you talked about, adding salt, you know, these waiting when at the side of the bed, and some of these things where we wear these support hose and things like that. Add the Florinef gingerly, and then probably Midodrine's the next. The one other thing about Midodrine is it's important that you don't lie flat within a couple of hours, maybe 3-4 hours, probably definitely not 2 hours of taking Midodrine, because it can actually make the blood pressure high. Even if you take a daytime nap or something, you have to be careful with taking the Midodrine in the day and then lying flat. So you should really be in the erect position when you're taking those medicines. I think that's very helpful.
And can I also add, ideally speaking, in an ideal situation, before prescribing compression stockings, we are supposed to get an arterial Doppler to make sure there is no underlying peripheral vascular disease, because some people may consider that as a relative contraindication. So that is to be noted as well.
So we just want to make sure that we are not having a clot in the legs. If we're starting these compression, and sometimes if you go in the hospital, they might actually put these compression boots on where it's actually like, you know, doing this. So often before we do that, we try to screen if there's a worry about or swelling in the legs and stuff. We try to screen to make sure there's no clots in the legs. I think that's very reasonable too. So I think that we're nearing the top of the hour here. Actually, that went by very, very quickly. So I think this was really helpful, Padma. Thank you so much for taking the time. Maybe I'll just leave you with a last couple of minutes just about sort of something inspirational. And also, maybe you can speak a little bit to how you think, you know, from a self-care perspective, if you think that exercise may help with the blood pressure regulation issues. Do you have a sense of that at all?
I'm a bit not very brave there. For someone with a 80 millimeter drop in blood pressure, I will be very much concerned to prescribe a full exercise program for that person. Maybe exercise sitting down, like a stationary bike, will be what I will be doing, or lifting up like a 3-liter pint of milk with each hand, alternatively exercise for the upper limbs, or passive stretching. If people are symptomatic with postural hypotension, we geriatricians are extremely paranoid about them having a fracture, having a fall and a fracture. So we must confess, I must confess that we tend to err on the caution and restrict the exercise on people with significant postural drop in blood pressure, because the last thing we need is a fracture off.
That sounds really good. Yeah, I agree. I think that seated chair exercises, and even in the bed, sometimes we can actually get some movement in the bed as well if people are feeling very dizzy when they stand up. So I think that, you know, the concept of having to walk, and certainly if you do have low blood pressure and you are engaging in exercise in the standing position or with walking, it's important to have somebody around you and possibly use a walker, because what Dr. Padma has shown is that we can have, when the blood pressure drops are actually happening, is usually 3 to 5 minutes after somebody's stood up. And so often what I see people doing is they stand up and they're like, I'm feeling pretty good. You know, they'll wait 10 seconds or 20 seconds and then they're off. And that's when minutes into when they're walking that they start to feel dizzy, and that's when they sort of fall. And so we just want to really be mindful of being as safe as possible. So that was really helpful, Padma. Thank you so much for taking the time. I really appreciate your you know, vantage point. And I think there's such a rich number of questions and all kinds of things from, you know, our chat here about swallow, about wanting to hear more about sleep. about all kinds of other thoughts, even about temperature regulation and things like that. So I think, you know, like you said, the more you get close to this disease, the more you find that there's complexities. And so I think we've just been really teasing these out one by one, and we are uncovering more and more questions and topics. So, so I appreciate you taking the time and waking up so early and keeping your dog quiet on that side of the world. And we really appreciate you taking the time. And I think for those on the call today, this will be on video. And so we've covered a lot, and every slide was quite dense with a lot of helpful tips, even about checking the blood pressure, what defines the drops and things, how to check the blood pressure. And so I think go back and watch this and maybe take some pauses and write some things down, because I think it's a very, very rich discussion that we've had today. And I think that, you know, it merits another view or two. So
thanks Andrew.
I'll hand it back to you, Andrea.
All right. Yes. Thank you to both of you. Thank you everyone for joining in today. And Dr. Padmakumar, we always wave goodbye. So we will send you some good wishes from the other side of the planet. If you have your video off, I invite you to turn it on, and you can scroll through and see all the smiling faces who learned something new from you today. Thank you so much.
Thank you, and thanks for the invite. I hope it was useful.
Yeah, very useful. Thank you. Take care.
Bye.
Now, bye everyone.